A warm good morning to one and all. Thank you for joining us for today's webinar. It's my pleasure to be a moderator for this webinar. I am Neetu Mohanan, Faculty of Sanjoe College of Nursing, Puluveri. On behalf of Sanjoe family, I welcome you all to today's webinar on topic Emergency Management of Critically Ill Patients, considering COVID-19 protocols organized by Medical Surgical Nursing Department of Sanjoe College of Nursing. Let us invoke blessings from the God Almighty. You will have a silent prayer. Thank you all. It's my great privilege to welcome our beloved principal, Professor Sister Shekhi. She is a person with great enthusiasm, compassion, and also rich with inspirational thoughts. Welcome you, sister. It's my honor to welcome our Vice Principal, Professor Sister Udaya Paul, and Administrator and Coordinator of this webinar series, Professor Sister Jansi Bibu. Welcome you, sisters. Next, with great pleasure, I welcome today's resource person, Sister Elsie KV, HOD, Medical Surgical Nursing Department, Sanjoe College of Nursing, and Dr. Minnie Paul, Senior Lecturer, Sanjoe College of Nursing. Welcome, sister. Welcome, ma'am. We are so excited to have you all here to participate in our webinar. I am extending a very warm welcome to all the delegates. Today's topic for the webinar is Emergency Management of Critical Care Patients Considering COVID-19 Protocols, organized by Department of Medical Sciences. We have two sessions. First session is about emergency management of critical care patients, and second session is about protocols related to care of patients with COVID-19 in critical care unit. Without further delay, we will turn the time over to Dr. Minnie Paul for the first session, Emergency Management of Critical Care Patients. Dr. Minnie Paul has done her PhD from MG University, Kottayam, MSc Nursing and Adult Nurse Practitioner from Long Island University in New York. She has done certifications in emergency nursing, medical detoxing, sexual assault, and forensic exam. She has attained proficiency in diverse aspects of the healthcare system as an emergency department registered nurse and as a nurse practitioner in New York and as a teaching faculty both in USA and in India. Now, she is the vital faculty of Sanjoe College of Nursing. Over to you, ma'am.
Thank you, Ms. Nedu. Very special good morning to one and all. Welcome to the webinar on Emergency Management of Critically Ill Patients Considering COVID Protocols. I am Ms. Minnie Paul, Faculty, Sanjoe College of Nursing. Overview of our webinar, Systematic Approach, Management of Acute Coronary Syndrome, Management of Bradycardia, Management of Tachycardia, Management of Cardiac Arrest, Post-Cardiac Arrest Care, and Management of Stroke. Critically ill patients are patients with severe respiratory, cardiovascular, or neurological derangement, often in combination, reflected in abnormal physiological observations. As a critical care nurse, it is our responsibility to identify these abnormal physiological findings early and manage the situations appropriately to prevent cardiac arrest. Critical care nurse offer the chance of tomorrow's goodness. As soon as you receive a patient from the ambulance to the hospital stretcher, you have to approach the patient systematically. Look at the general appearance of the patient, whether the patient is unresponsive or responsive. The patient is unresponsive, you go for BLS assessment. The patient is responsive, you go to the primary assessment, then to the secondary assessment. How will you go for BLS assessment? You have to check whether the patient is in cardiac arrest. How do you check whether the patient is in cardiac arrest? You have to check the pulse, carotid pulse for the adult and child, brachial pulse for the infant. If there is no pulse, patient is in cardiac arrest. Immediately start with compression first. You have to re-establish blood circulation because the heart is arrested. There is no oxygen is carrying out through the blood because the heart is arrested. So we establish circulation by giving compression first, then airway, then breathing, then defibrillation. CABD. On the other hand, if the patient is responsive, you can go straight to ABCDE, airway. You have to clear the airway. Airway should be patent. You have to do the suction sometimes. Many times, patient's own tongue can fall back and can obstruct the airway. So a simple maneuver like head tilt. With one hand, you can tilt the head, and with the other hand, you can lift the chin. Head tilt and chin lift can open the airway. Many times you have to consider advanced airway like intubation, endotracheal tube, or laryngeal mask airway, or combi tube. Once you clear the airway, look at the breathing, whether he is in agonal breath. He is in agonal breath. That is an early sign of cardiac arrest. Immediately you have to go for the ventilation. Even you can go for back mask ventilation. Connect the ET tube to the ambu bag. If the ventilator is available, set the ratings at 12 breaths per minute. Okay. After the breathing, you have to connect the patient to the cardiac monitor. Look at the circulation, how his ECG, how is the pulse, how is the respiration, how is the saturation, oxygen saturation, how much it is. Okay. You can look at the capillary refill, how he is cyanosed or pale, whether he is dehydrated, get an IV access. If he is dehydrated, blood pressure is down, hypotensive, give IV bolus with a ringer lactate or normal saline. After the circulation, you can even, if the patient is complaining of chest pain, even ECG comes as a primary assessment. So after the circulation, look at the neuro disability, whether his pupil is round, reacting to light and accommodative, whether the patient has any warning signs of stroke like facial droop, arm drips, slurred speech, whether he is alert oriented to times three, whether it is to the time, place, and person, whether he is alert only to the voice or only when you inflict pain he is alert, or whether he is unresponsive. Then expose the patient and look at the patient from head to foot. Look for any unusual marks, whether there is any bleeding point, stab injury, gunshot injury. So even though I explained to you like ABCD, you can do all these steps, all these assessments simultaneously while transferring the patient, after while undressing the patient to the hospital gown. Look from head to foot and look at the airway, breathing, talk to the patient, connect the patient to the cardiac monitor, look at the circulation status, disability. So do the primary assessment simultaneously. Once you finish with the primary assessment, go to the secondary assessment. Secondary assessment, you go for focused medical history. Look at the signs, ask the significant other, what are the signs and symptoms? Whether he is allergic to any medication, what medication he is on, whether he is on any diabetics medication, antihypertensive medication, what is his past medical history, he has any history of seizure, whether he had any surgical history like coronary reperfusion surgery, any procedure he has undergone, when is the last meal he had. Okay, if it's an infant, when is the last time infant had breastfeed? All those you have to ask focused medical history and events leading to the present situation. What exactly brought the patient to the emergency department? Whether he was watching television, whether he was engaged in sports activities outside, whether he was in a swimming pool. So events leading to the present situation. So along with the primary assessment, secondary assessment, and the investigations result like lab result, chest X-ray, echocardiogram, ultrasound, whatever investigation is available, all those everything together, you go to the definitive diagnosis. Before going to the definitive diagnosis, you have to think about the differential diagnosis. To remember the differential diagnosis, it's easy for you to remember 5 H's and 5 T's. First H is hypovolemia, whether he has any signs or any complaints of vomiting or diarrhea, hypoxia, whether he was a drowning victim, hydrogen ion, acidosis, alkalosis, hyper or hypokalemia, hypothermia, whether toxins, suicidal or homicidal attempt, tamponade, cardiac tamponade, or tension pneumothorax, thrombosis, coronary or pulmonary. So think about this H's and T's, then comes to the definitive diagnosis. The patient comes to the emergency department with chest discomfort or chest pain. The same way you go to ABC, primary assessment, you can take an ECG. Meanwhile, taking the ECG, you connect the patients to the oxygen. You can give nitrates. and you can give aspirin 160 to 325 milligram. You can consider morphine. Okay, so it's easy to remember when you think about Onam: oxygen, nitrate, aspirin, and morphine. While getting the ECG, you have to interpret the ECG. There can be three conditions. ECG can be ST elevation MI, or it can be ST depression or T wave inversion, or it can be a normal ECG. If it is an ST elevation MI, of course, the time is critical, time is crucial. The coronary artery is blocked. Your goal is reperfusion, immediate reperfusion. There is no time to waste. So you can reperfuse the heart. Reperfusion, you can do it either by giving thrombolytics or by PCI, percutaneous coronary intervention. Check whether the patient is an eligible candidate for thrombolytics like streptokinase or alteplase, whether the symptom of onset is within the last 12 hours, whether he is okay with the checklist of fibrinolytic therapy, if he had any history of atrial fibrillation, cerebrovascular accident, any bleeding, you have to consider PCI, not a good candidate for thrombolytics. So, for if you consider thrombolytics, you have to, the time is crucial, I said. So, you have to go from the door to needle or door to thrombolytic is 30 minutes. And if you are considering PCA, percutaneous coronary intervention, or balloon angioplasty, the door to balloon time is 90 minutes. Okay. And if the ECG is like just showing ischemic changes like ST depression or T wave inversion, you can give oxygen nitrate, aspirin, and morphine, and you have to give low molecular weight heparin. You can consider clopidogrel, beta blocker. You can consider check the patient continuously, cardiac monitor the patient, then check the ECG and cardiac markers like CKMP troponin every 8 hours. And if the ECG is normal and patient is complaining of chest discomfort, still you don't discharge the patient. You have to admit the patients to the chest pain unit. Do all three every 8 hours: ECG and CKB, troponin, electrolyte studies, coagulation studies. All that you have to do it. And if everything is normal, only you discharge the patient. So continuous cardiac monitoring is very crucial to this patient. If the patient's heart rate is 70, saturation is 90, blood pressure is 120, 80, the patient looks stable. Suddenly, the patient's heart rate goes down from 70 to 50. You know the patient is going to bradycardia. Immediately, you go to the bradycardia algorithm. How you manage a patient with bradycardia? Assess appropriateness for clinical condition. Heart rate typically less than 50. If bradyarrhythmia, identify and treat the underlying cause. Give oxygen, maintain patent airway, cardiac monitor, IV access, and 12 lead ECG. Monitor the patient whether the blood pressure is going down, hypertension, whether he is having any acutely altered mental status, whether he has any signs of shock, whether there is any ischemic chest discomfort or chest pain, any pulmonary rails or on auscultation, acute heart failure signs. If nothing is present, patient is stable. So you can just monitor and observe. But any of the signs like blood pressure is going down, he has acutely altered mental status, signs of shock, that shows patient is unstable. So hereafter, you will say patient is in unstable bradycardia or stable bradycardia. Don't just say patient is in bradycardia. Say whether the patient is unstable bradycardia or stable bradycardia. The patient is in unstable bradycardia, you have to immediately give atropine. How much atropine you can give it? You can give atropine 0.5 milligram. Maximum you can give is 3 milligram. Okay, if atropine is ineffective, you can go for transcutaneous pacing or you can go for medical pacing. Medical pacing is either you can give dopamine or epinephrine. Dopamine you can give 2 to 20 microgram per kg per minute. Epinephrine you can give 2 to 10 microgram per minute. Okay, if transcutaneous pacing or medical pacing didn't work out, the patient's heart rate didn't come up, you have to go for expert consultation and transvenous pacing. Look at this rhythm. The heart rate is 50, blood pressure is 110 over 70, saturation is 98. Here the patient is stable. You don't have to do anything. You just have to continuously monitor the patient. Look at this condition. The patient's heart rate is 54, blood pressure is 80 over 70, and saturation is 88. Here the patient is in unstable bradycardia. You have to go for atropine. Maximum you can give 3 milligram, or you can go for medical pacing or transcutaneous pacing. Doesn't work? Go for transvenous pacing. Okay, when while monitoring, if the patient goes to tachycardia, you have to first thing what you have to check whether the patient is having pulse or not. The patient is tachycardia without pulse, patient is in cardiac arrest. Tachycardia with pulse, the algorithm you go to tachycardia with pulse algorithm. Heart rate will be more than 150. The same like bradycardia, you can give oxygen, maintain IV fluid, and you have to continuously monitor the patient for blood pressure, hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If any of these signs is present, you have to go for synchronized cardioversion. Here you don't have time to waste with trying with medication. Go directly into synchronized cardioversion. Only if regular narrow complex, you can consider adenosine. So synchronized cardioversion, again to select the joule. If it is narrow regular, you can go for 50 to 100 joule. Narrow irregular like atrial fibrillation, you can go for 120 to 200 joule. If it is wide regular like monomorphic joule, monomorphic ventricular tachycardia, you can go for 100 joule. On the other hand, if the patient is stable, you have time to take an ECG and look at the ECG whether the ECG is wide complex QRS or it is narrow regular complex QRS. If it is a wide complex QRS, wide regular complex, you can try adenosine and you can go for antiarrhythmic infusions like amiodarone. And if it is a narrow regular complex tachycardia like SVT, here you can try for vagal minor or carotid sinus massage with a thumb where you check the carotid pulse. Give a massage for 5 seconds. That will block the vagal stimulation and reduce the heart rate. So go for vagal maneuver. If it is narrow regular complex tachycardia doesn't come out, the patient don't convert into normal sinus rhythm, you can go for adenosine. First dose is 6 milligram and next dose is 12 milligram. You can go for beta blocker or calcium channel blocker and expert consultation. Look at this. The patient is in tachycardia SVT. Heart rate is 176 and blood pressure is 118 over 70 and saturation is 98. Here, patient is in stable SVT. You can go for vagal maneuver. Doesn't work. You can go for adenosine 6 plus adenosine 12 milligram. Okay, expert consultation you can call. And look at this here again. Narrow regular complex. Patient is in SVT. Look at the blood pressure. It is 80 over 70. Hypotensive. Saturation is going down. Patient is in unstable SVT. You don't have time to try for vagal maneuver or try for adenosine. Straightly go into synchronized cardioversion. How much joules you can select? You can go for 50 to 100 joules. Put the patient defibrillator into sync mode, charge into 50 to 100 joule and shock the patient. Before giving synchronized cardioversion, you can consider 3 C's. What are the 3 C's? Consent, crash cart, and consider sedation. Look at this. Patient is in wide regular complex tachycardia, monomorphic PT. Here the patient is stable, blood pressure is okay, saturation is okay. You can consider adenosine for this patient and antiarrhythmic infusion. Look at this patient here. Blood pressure is down 70 over 50 and saturation is 80. Patient is unstable. He has pulse but unstable monomorphic PT. You go for synchronized cardioversion. You can select 100 joule and give the synchronized cardioversion. At the peak of the R wave, you give the shock. Okay, if you don't manage this bradycardia or tachycardia appropriately, the patient may go to cardiac arrest. Immediately, you have to go to the cardiac arrest algorithm. I told you in the primary assessment, if the patient is unresponsive, check whether the patient is in cardiac arrest or not by checking the pulse. There is no pulse, patient is in cardiac arrest. Start CPR immediately, compression, airway, breathing, and defibrillation. Okay, when you give compression and defibrillator is available, connect the patient to the defibrillator. Check at the rhythm whether the patient is in ventricular fibrillation or ventricular tachycardia or asystole or PEA. Ventricular fibrillation and VT, patient will not have pulse. Asystole and PEA also, patient will not have pulse. But if even the patient is in cardiac arrest, depend upon the rhythm to manage the cardiac arrest. This side I have written ventricular fibrillation and ventricular tachycardia. Here the heart is quivering. There is no formed contraction. So there is too much electrical activities in ventricular fibrillation and ventricular tachycardia. So defibrillation is important. You can select the joule. Biphasic means 200. Monophasic means 360. So select 200 joules and deliver the shocks. Defibrillation. After the first shock, you can give CPR 2 minutes, then check the rhythm. Again, if it is shockable rhythm, give second shock, give the CPR. After while this CPR is on progress, you can give epinephrine 1 milligram. Next shock, you can give amiodarone 300 milligram. Next shock and CPR, you can give epinephrine 1 milligram. Next shock, you can give amiodarone 150 milligram. So after the shock and CPR, medication what you can give? Epinephrine every 3 to 5 milligram. Amiodarone you can give only 2 doses. First dose is 300 milligram and next dose is 150 milligram. On the other hand, if the cardiac arrest is asystole, here the flat line or pulseless electrical activity, it is not too much electrical activities going on. So there is no need of defibrillation. You have to just give CPR, compression and airway breathing CPR. Just give high quality CPR and you can give epinephrine every 3 to 5 minutes. You don't have to give shock when the patient is on asystole or PA. Look at this. Patient is in cardiac arrest. Heart rate is 0. He is in polymorphic ventricular tachycardia. Start CPR, defibrillation, and epinephrine and amiodarone you can give it. Look at this. Patient is on ventricular fibrillation. No pulse. You can give CPR, defibrillation, epinephrine, and amiodarone. Only 2 doses of amiodarone. First dose is 300 and next dose is 150 milligram. Look at this. Patient is in pulseless electrical activity. Some electrical activity is there, but there is no pulse. Pulse is vacant here. So you have to just give CPR. Look at this. Patient is in flat line. Heart is not functioning at all. Flat line, asystole. You have to give CPR and you can give epinephrine 1 milligram IV push every 3 to 5 milligram. Every 3 to 5 minutes, 1 milligram IV push followed by saline flush. Okay. So once you manage the patient with cardiac arrest appropriately and patient came back to life. If the patient come back to life, the term is known as return of spontaneous circulation, ROSC achieved. If return of spontaneous circulation or ROSC achieved, you have to give post-cardiac arrest care. Otherwise, the patient will go to second cardiac arrest again. So what you have to do? You have to maintain oxygen saturation. You have to stabilize the patient hemodynamically. You have to saturation. You have to maintain 94% systolic BP. You have to maintain above 90 millimeter of mercury. For that, you may have to give IV or IO bolus, intravenous or intraosseous bolus, normal saline or ringer lactate. You can give it. You can give vasopressor infusion like dopamine infusion. Consider treatable causes and take 12-lead ECG. Check whether the patient follow commands or not because he just had a cardiac arrest. If he don't follow commands, no, just consider induced hypothermia. You can give 4 degrees Celsius cold saline. Of course, critical care unit will be air conditioned. Hypothermic blanket you can give it. If he follow commands, take an ECG and check whether patient has ST elevation MI. Maybe that was the reason for cardiac arrest. Immediately call the cath lab for coronary reperfusion. After the coronary reperfusion PCI, move the patient to critical care unit, coronary care unit. Okay, so if the patient, this circulation part we have taken care, and if the patient is having stroke, CVA, when you assess ABCDE disability, you check the patient in stroke, you have to manage the patient with 8 Ds of care. What are the 8 Ds of care? You have to detect whether there is warning sign of stroke, whether the patient has facial droop, arm drift, slurred speech, and time of last non-normal fast, FAST. You have to act fast. It's easy to remember. Facial droop, arm drift, slurred speech, and time of last non-normal. Ask the patient to smile if there is facial droop. Ask the patient to extend both arms if it is drifting down. Ask the patient to repeat a sentence if there is a slurred speech. When is the last time non-normal? You have given dinner to the grandfather at 8 p.m. He was normal. 10 p.m. you want to take him to the bed. He is having slurred speech or facial droop. You know, last non-normal is 8 p.m. The window period for thrombolytic is within 3 hours. So 8 p.m. he was last non-normal. 9, 10, 11. Within 3 hours, you have to give. Within 11 o'clock, you have to give thrombolytics or recombinant tissue plasminogen activator. So time is crucial. So you have to dispatch the patient. You have to dispatch ambulance dispatch. Then deliver the patient fast to the right door. Why it is right door? You don't have to take the patient to a small hospital. Small hospital will not have CAT scan, CT scan. CT head we have to do to know whether the patient is in ischemic stroke or hemorrhagic stroke. So you have to deliver the patient to the right door. Once the patients reach the right door, it is your responsibility to collect the data. You have to collect the data. I told you, focus medical history, get the IV access, lab report, get the data, and CT scan is very important. You have to check whether the patient is on ischemic stroke or hemorrhagic stroke by reading the CT scan. If the patient is in ischemic stroke or hemorrhagic stroke, you have to take the decision. What decision you will say? You will take the decision whether it is drug, thrombolytics, or device. Is it the surgery? Ischemic stroke, you can give thrombolytics or recombinant tissue plasminogen activator. If it is a hemorrhagic stroke, you are going for neurosurgery. So think whether it is drug or device. If it is after the thrombolytics or after the neurosurgery, you have to disposition the patient to the neuro ICU. So 8 Ds of care. Fast you have to facial group, arm drift, slut speech, and time of last non-normal you have to know. Fast you have to be in action also as a critical care nurse. You can save life. My bibliography. Thank you. Your participation is key to our success. And webinar on emergency management of critical patients considering COVID protocols. The COVID protocols, Sister LCKV will deal with it. Miss Needu, over to you, Miss.